The next speaker is Dr. Tarun K. Mittal, who is a senior consultant cardiothoracic radiologist, Royal Brompton and Harefield Hospital, UK. He is also a senior lecturer in Imperial College, London, and he has a lot of interest and a lot of data in the European world. I'm sure it will be of a great interest to all of us, and we'll have the Indian part on one side and European part on the other side. Let's see what Tarun has to say. Tarun.
Om Shanti. First of all, I would like to thank Dr. Chopra and Dr. Gupta for the invitation and opportunity to come and present at this prestigious meeting, but more importantly to introduce me and all of us to the wonderful world of Brahmakumaris and the program of lifestyle intervention. So the topic of my talk is role of calcium scoring in patients with chest pain. So as both the previous speakers, Mona and Priya, have gone through, we have multitude of imaging techniques now to evaluate patients with cardiac disorders and also with patients with chest pain. So I'm going to confine this topic to stable chest pain or stable angina, as for acute chest pain, calcium scoring probably today does not have significant role. So we can divide the different techniques available to us as under anatomical imaging, under which we have the cardiac CT and conventional catheter angiogram, and we have then numerous stress imaging techniques which can be performed to evaluate functional significance of underlying stenosis. So calcium scoring is probably one of the basic of all these techniques, and next 15-20 minutes I will go through how we can use calcium scoring effectively for our patients in a cost-effective manner. So what does coronary artery calcification means? So when we see calcified plaque in a coronary artery, it appears as areas of bright density, as we can see on this image here. And this represents atheromatous plaque. Calcification is a very specific, 100% specific marker of atherosclerosis, and there is no other condition in which we see calcification in the coronary arteries. But calcium is only one of the components of the atheromatous plaque, as you know. So plaques can have fibrous element, they can have lipid core, and they can be other material like smooth muscle cells, macrophages, etc. The composition of the different components in the plaque varies upon its age at any point of time. In this diagram, we can see that the earliest plaque developed in the form of fatty streak, which can be seen as early as second decade of life on post-mortem studies. The calcium in the plaque starts at around third or fourth decade of life, it's seen here, and then gradually as plaques develop, the calcification can also continue to progress in the plaques. But as shown in this diagram, calcium stays there in the plaque all throughout and is a precursor or can be a precursor long before the plaques rupture or they develop obstructive flow-limiting stenosis. So when we see loss of calcium in the coronary arteries, it just means that there is a larger atheroma or plaque burden in the coronary arteries. But it doesn't mean that all the plaques in the arteries are calcified. There would be non-calcified or soft plaques in the coronary arteries, and it is these soft plaques that are responsible for acute rupture and thrombosis and producing symptoms of angina. If there are no calcified plaques in the coronary arteries, that means either there is complete absence of plaques or there could still be soft plaques in the coronary arteries. So we have to bear this in mind. Now, the first time the calcium in the coronary arteries was associated with atheromatous disease was in 1960s when cardiologists and radiologists started to perform coronary angiography or fluoroscopy in patients coming with chest pain. So the association of calcium was realized at the time. And then in 1980s and 90s, electron beam CT scanners came about, which were extensively used to assess the calcium in the coronary arteries. And a lot of data we have today is from those studies. And since the beginning of this century, we are using multi-slice CT scanners to identify calcium. And obviously, we can use other invasive techniques like intravascular ultrasound. Now, CT in the form of multi-slice CT by far remains the largest or the best used technique for assessment of coronary artery calcification. CT is a very sensitive technique to detect calcium in the coronary arteries. So a CT scanner looks like a donut-shaped machine, and it's similar to MRI, but it has a shorter tunnel. So tunnel is longer than MRI. That's the only difference, and plus this is an X-ray technique while MRI uses magnetic radiation. So like other, like any cardiac imaging technique, the scan is performed with ECG gating. So 3 leads are placed on patient's chest, and the scan image acquisition is gated or tuned to patient's heart rhythm. For performance of calcium scoring, we require only 4-slice CT scanner or higher. For CT angiography, as Priya said, we require at least 64-slice CT scanner or higher. The scan is performed from the level of the carina down to below the heart. Similar region is covered for CT angiography as well. An important thing with CT calcium scoring is that there is no need for beta blocking because there is no need for reduction of the heart rate. No intravenous contrast is required, and no stress imaging agents are required. It's a very simple, quick procedure, takes not more than 10 minutes to perform and to report. And because of lack of requirement of any drugs, any agents, quick turnover, the exam is overall much cheaper than the other imaging investigations. So not all calcium is considered to be quantifiable for calcium score. So you have to have 3 or more adjacent calcified pixels with Hounsfield units or density of more than 130 units to be able to call calcified plaque for the proper scoring. There are various techniques how which we quantify the plaques. So the most common one is called the Gadsden calcium score, which is named after a cardiologist called Arthur Gadsden, who is also popular for his South Beach diet in US. So number of authors like this particular study in 35,000 asymptomatic people coming for well screening checks in US have produced data like this. So this is distribution of calcium in asymptomatic people, and we can see here how the calcium increases with age. And in men it is obviously more compared to women, which lag by about a decade or so than men. So this is the normal distribution, and age is our biggest risk factor. So calcium burden increases with age. And this data can be put in charts, looks very busy, but this is basically distribution of calcium score with increasing age and in both men and women, and basically demonstrating the calcium score as age and sex percentiles. And when we quantify the calcium on the software, it gives us chart like this. So here blue, the red dot here represents the score of this patient in terms of age and sex percentile. And these percentile graphs are useful in younger people, say less than 40 years of age, or who have calcium score of less than 100. Now, so the topic that has been given to me is the use of calcium score in stable chest pain, which I'm going to now go through. So any imaging technique in assessment of stable chest pain, there are 2 objectives. The first is to exclude obstructive coronary artery disease, and second is to determine prognosis. So let's look at first. So when the patient comes to us as doctors, the first thing we do is to assess the patient clinically. So assess the symptoms of the patient. Is the chest pain non-anginal? Is it atypical chest pain, or is it typical angina? Then based upon patient's age, sex, and the risk factors, we try to assess the pre-test likelihood or probability of having significant coronary artery disease. We have various tools, like the commonest one probably used throughout the world is the Diamond Forrester classification for pre-test probability. This one is from the Duke's data. This is what we use in United Kingdom and is recommended by a body called NICE. So this gives us a number, and it divides patients into low, intermediate, high pre-test probability. So based on the pre-test probability of significant coronary artery disease, we can have low to intermediate pre-test probability, and most of the guidelines agree that in this pre-test probability, a non-invasive test is probably best to exclude significant coronary artery stenosis. So you could be using anatomical tests like cardiac CT or a stress imaging test like echo, nuclear, MRI, etc. And for high pre-test probability, most people would use a conventional angiogram to exclude obstructive disease. So what's the role of calcium score in these patients? So if we do a calcium scoring scan, the score can be 0 or it could be anything more than 0, anything 1 or in thousands. So let's look at the presence of calcium in the coronary arteries. What does it mean? So this was a meta-analysis that was published in 2009, looking at 18 studies in patients with typical angina going for a conventional angiogram. So you get 10,000 patients, and a calcium scoring scan was done as part of research study. Now these studies showed that the sensitivity and specificity of calcium score of 100 or more than 75th centile to exclude significant coronary artery disease of more than 50% is about 75%. So score of 100 or 75th centile or more can be used as a cutoff value. But that's a vast range. 1 to, in hundreds or thousands is a vast range. What do you do? So we don't have, we can use 100 points cutoff point, or some people use 400 as a cutoff point. But in the era of CT angiography and other stress imaging techniques, the best thing is if you have any degree of calcium score is to proceed for those techniques, which could be a CT, it could be a stress imaging technique, or if patient is of high pretest probability, then proceed for a catheter angiogram. So what about the calcium score of 0? So absent calcium score. So the question is, how many patients presenting with stable symptoms have a calcium score of 0? And second, what is the prevalence of obstructive CAD in patients with calcium score of 0? So can we say that patient with calcium score of 0 is safe? We can leave the patient alone. So again, same meta-analysis, 10,000 patients who had both calcium scoring and conventional angiogram. The prevalence of calcium of 0 in these patients with typical angina, as they were going for a cath, was 20%. And significant coronary artery stenosis of more than 50% was seen in only 2% of patients. So a low prevalence of obstructive disease if you have calcium score of 0. Then when we started to use CT coronary angiogram in stable patients, there were 2 studies which were widely quoted, and they demonstrated that in presence of calcium score of 0, there was a significant proportion of patients, almost up to 19%, who could have obstructive coronary artery disease. But when one looks at the data closely, what the patient group they used, actually up to 40% of the patients had acute coronary syndrome. So they were not patients with stable symptoms, and that's a distinction that I would like to make, that we have to use the imaging technique based on patient's presentation, based on patient's symptoms. That's very important. Then further studies have shown, which are in patients with stable symptoms, that the prevalence of calcium score of 0 is anywhere between 40 to 50%, and the prevalence of more than 50% stenosis in these patients with calcium score of 0 is anywhere between 1 to 3.5%. So at Harefield Hospital, where I work, we looked at around 4,000 patients since 2003 who have undergone both calcium score and CT coronary angiogram. And we had a mean follow-up of 5.2 years. And if you look at this bar chart, you can see that the pretest probability was fairly equally spread out. Almost 30% patients were falling in high pretest probability group. So what we saw was that almost 50% of the patients had calcium score of 0. And in these patients, 1.2% patients had moderate stenosis between 50 to 70%, and 0.5% patients had severe stenosis of more than 70% or more. Now, when we subjected these patients to stress imaging or conventional angiogram, then only 0.3% patients had flow-limiting stenosis. So a very low proportion of patients have true flow-limiting stenosis if you have a calcium score of 0, which gives a calcium score of 0 a negative predictive value of almost 99.5%. So the answer to this question now we have is that almost half the this patient cohort would have a calcium score of 0, and of those, very low proportion of patients would have obstructive coronary artery disease, almost less than 1% we can say. So second question we have is how does calcium score helps in prognostication? So again, meta-analysis of 4,000 patients who underwent both calcium score and angiogram. Mean follow-up of 3.5 years showed that if you have calcium score of 0, your annual event rate is 0.5% versus 2.6% if you have any calcium of more than 0. This is a large confirmed study which had enrolled 10,000 patients from multiple centers with a follow-up of 2 years. And they found that if you have calcium score of 0, with or without stenosis on CT angiogram, there is no difference in all-cause mortality. But they had 5 times more event rate if you include revascularization, which you can see is a soft endpoint, and how if you see on imaging technique presence of plaque causing stenosis, you might be tempted to intervene. From our own data, if you have calcium score of 0, your annual event rate is 0.3%, and for any degree of calcium, it's 1.2%. And very interestingly, again, just to confirm the confirmed study data, this is patients with calcium score of 0, irrespective of the presence or absence of soft plaque on CT coronary angiogram, there was no difference in all-cause mortality over a mean follow-up of 5 years. So a calcium score of 0 is giving us a good guarantee of at least death. What about patients who have any degree of calcium? So we can see here, the more the calcium you have, the worse is your survival. And similarly, the more the stenosis you have on angiogram, CT angiogram or coronary angiogram, the worse is your survival again. But when we combine the presence of atheroma burden with calcium score versus stenosis, what is the relationship? Now, our data has shown that irrespective of the degree of stenosis, whether it's more than 25%, more than 50%, more than 70%, on multivariate analysis, the degree of calcium score is much more significant in terms of prognosis compared to the luminal stenosis. This is again a very important piece of data that we have. And this was demonstrated earlier on data from EBCT scanning in 2,500 patients with a long follow-up, where they showed that in patients with non-obstructive stenosis, the degree of calcium score actually was prognostic for all-cause mortality as well as MACE events. So calcium score is representing the atheroma burden and hence prognosis. So a calcium score of 0 represents very low cardiovascular risk, and increasing calcium score represents increased risk over and above the degree of stenosis. So again, an important point that whatever the luminogram shows, whether it's CT angiogram or an invasive angiogram, or whatever the ischemia test shows, the atheroma burden using calcium score is a very powerful technique for management. And again, next point I would like to make is that it is not a presence of a calcium in a particular point in the coronary artery that relates to stenosis. It is the overall score that is important. So an example here, this is a young female with complaint of acute chest pain. She had quite high calcium score. You can see here in LED. Angiogram was done. So her calcium score was 652, which is a very high calcium score for a woman of this age. And her coronary artery at this point in LED is looking almost normal. But on the right side, she had a very tight stenosis, and this was the culprit artery because of which she presented. So why is there no stenosis here? And as Priya had alluded in her talk, that is a process called external remodeling, in which the arterial wall expands. So you may have lots of plaque in the wall, but because of expansion, there is no luminal narrowing. But these are the plaques that tend to rupture and cause acute MI. Now how else is CT calcium score helpful? So it shows us, say, other causes of chest pain, like in this case, there is calcium in the aortic valve. So this patient can have severe aortic valve stenosis. In this patient, there is thickening of the pericardium, so acute pericarditis or chronic recurrent pericarditis, which could be causing chest pain. And this patient, there is hiatus hernia. And again, this is very common finding on both calcium scoring scans and CT angiograms. And as we had a talk yesterday from an expert, GI expert, that up to 1/3 of patients could be having reflux symptoms which could be associated with chest pain. The advantages of using calcium score is it's Easy technique overall, easy to detect calcium, easy to quantify the calcium score. It can be performed in patients who cannot exercise, which I would think is a significant proportion of our population. In patients with left bundle branch block, there's no need for any intravenous contrast, beta blockers, stressing agents. It's a cheaper technique, and the radiation dose is overall quite low at around 1 millisievert. So the way I look at, with our experience at my hospital, how we can use calcium score in a sensible manner is first we perform the pretest probability scoring. Then in patients with very low, then we consider them as patients with having non-cardiac chest pain. In those with very high pretest probability, they are probably having typical angina, they could go for a cath. In those with anywhere between 10 to 90% pretest probability, calcium scoring can be used as a first line technique. If you have calcium score of 0, they again become non-cardiac. If you have a calcium score of anything more than 0, then they can go for a CT angiogram. If there is less than 50% stenosis on CT angiogram, they can again be classified as having non-cardiac chest pain. If they have more than 50% stenosis, they could go for a stress imaging test. They can go for a conventional catheter angiogram. And it's a very cost-effective technique. Now, depending upon what the cost of the calcium score and other techniques are, you could be saving as much as 50% in terms of using calcium score as the first imaging technique in patients with stable symptoms. So to conclude, CT calcium scoring is a useful first-line investigation in patients with stable symptoms. Second, calcium score of 0, which is present in almost half the population, at least in the Western studies, can be used to triage patients, because calcium score of 0 means a very low prevalence of obstructive coronary artery disease. It has an excellent prognostic value. And next, any calcium score is again useful as a tool for atheroma burden itself. And it could be used as a target for further investigations, further imaging investigations, and further management. And most importantly, the atheroma burden aspect of it, I think, should be very useful to suggest lifestyle intervention in the sense as Raj Yoga and other methods, because that's what we need, I think.
Thank you very much, Dr. Tarun. I think it's given a very beautiful presentation with the calcium scoring. May I request you to kindly join us on the dais here.